So I got hold of the test finally. We'll whittle some things down in this section when we talk a little bit. There's only 2 or 3 questions on irritable bowel syndrome, so doesn't mean don't study it. Colonel Sylvester, Colonel Jenner, here's what he said. Okay. But I'll go with this. So make sure we're talking about irritable bowel syndrome, not inflammatory bowel syndrome. That's the realm of Crohn's and what's the other one? Ulcerative colitis, yeah. So those are different types of things. So irritable bowel syndrome, 28 slides to the next deal, and 1 or 2 decks from Freedom. So different styles here. So idiopathic, again, that means we don't know what really causes it. Because people are going to have abdominal pain. Now, I want you to see that says chronic and recurrent. People deal with these symptoms for a long time. Can I figure out what the cause is versus making sure it's not a functional bowel disorder? I got some other slides here that are coming up. Extraintestinal manifestations, I don't want to steal that thunder yet, but just know that this is kind of giving us what we're going to talk about here. Unfortunately, yeah, there's no specific lab test that we're going to do for these folks. We want to make sure that we exclude all the other bad stuff and then get into this. So, here's your pathophys. Really happy with Major Kelly for all these pathophys questions. We'll talk about it a little bit. I'll let you know, looking at that test, it's more important that you know how to treat these, not exactly why they're caused that way. By the way, no patient really wants you rambling on about pathophys. They really do. Just, I got shit to do. Take care of me, doc, and keep me moving. So, we have this multifactorial in nature. So just look at that. Alterations of gut, microbiome, so food sensitivity. So we're looking at a bunch of different things. I really want you to pay attention. That's psychosocial dysfunction. Anyone gets into this, I put irritable bowel disease in the realm of fibromyalgia. Like, how do we get this? And I guarantee you, if you have fibromyalgia, you probably have irritable bowel disease too. You're like 39 years old and on 15 different medications. Ugh. Those people suck the life out of me. It's rough. At least you know what you're dealing with. Yeah. You ask for review systems and say yes to everything. Are you kidding me? You're going to document that? Probably not. Not practicing that. All right, so look at these different types of things. So crampy, intermittent abdominal pain. So usually the lower quadrants, usually not an upper thing, usually not epigastric pain. So a lot of these people report that after they use the bathroom, they feel a lot better. So again, constipation, diarrhea, the change in stool frequency, form. This next one's a doozy. If you looked at the slides before, I hope you did, but if not, no big deal. But so these people complain of bloating, probably tried some Simethicon. But I think this is probably the best slide I've seen in a long time. I want you to describe your poop. Are you type 1 or type 7? Maybe a little bit of 3 and 4? I don't know. I just think it's pretty cool that, like, if you're like a gastro guy, that you hand somebody a chart, like you have a pile of them just sitting on your desk. Hopefully they're laminated. Just food for thought. No pun intended. All right, moving along. Here's our subtypes of this, because we get an idea of what's going on there based on the consistency of the stool, because we have our IBS-C, hence the C for constipation. So, man, only less than 3 BMs in a week. So, with a lot of straining, so they're testing that bowel salve out, right? And see if they're going to pass out in the toilet or not. At least 3 times a week. Pretty cool. And then we have our diarrhea predominant. So you get an idea of that, because that just is going to steer you with what medications that we're going to go with. So they're typically more than 3 bowel movements a day. That's things. And you can have your mixing, a little bit of C, you can go back and forth with that. So So I talked about extra intestinal manifestations. He's just kind of run with a lot of these things. Dyspepsia, heartburn, those are kind of synonymous. Some chest pain, if a gastric pain. So these people are just giving you all kinds of review of systems when you're asking them, do you have this? And just get ready, we're just going to open this door. So gynecological symptoms for women as well, and urologic symptoms for that. So increased frequency, urgency, that. So maybe some polyuria. And then we ran with anxiety and depression. So probably a little bit of factor on that. I want to make sure that we're doing a good review of systems, but also good family history, past medical. We want to make sure that we're not missing these other types of things that can stimulate that. So there's potential for a decent workup here. Right? Want to ask about their medication, their diet, exercise changes. And then, of course, want to make sure not dealing with some crazy travelers, diarrhea, something else that you get when you're downrange or whatever. Want to check that. So atypical symptoms, this is not compatible with irritable bowel syndrome. So we need to be thinking about other things if they're complaining of bleeding from the rectum. So worsening abdominal pain, especially at night. Weight loss, oh man, that can mean a number of things, but I always want to make sure I'm not dealing with the cancer. And then we do get some labs to check all that type of stuff. And then family history of GI disease can really clue you in. They have a history of celiac sprue, tropical sprue, whatever, or maybe an early family history of colon cancer. And I say that, I get really worried when people tell me, yeah, my grandmother was diagnosed with colon cancer when she was 40. Because we don't screen for that until they're 45. But if you go back and ask those people history, they're like, yeah, I had a lot of rectal bleeding. I didn't think it was anything. Well, the C word, cancer, not anything else. Some of you are sick in the head, okay? But, so we worry about that. Cancer does not get better with time. We need to check those types of things. So, study, imaging study, these are red flags in my opinion, okay? Maybe need a colonoscopy. We're going to make sure that we exclude these organic etiologies first. So, this is a chronic condition. Anybody comes in with something acute, we should probably think of maybe this is for surgery. It's not in the realm of irritable bowel disease. So, again, your differential is very important. Your differential is very important. We need to be thinking about all these other things. If we don't have these on our differential, we don't diagnose it with things before. Unless you get lucky and you need a CT scan and the radiologist reads it as, oh, this likely is a colon cancer. It's good that opportunity to go in there and do colonoscopies and stuff occasionally. Yeah, you do find some pretty interesting things. But just realize we have a lot, and we've talked about some of these things. Especially our lactose intolerance. So asking people, what do you need? Or your family history, we can figure that out. I really don't like these slides that just say usually unremarkable. Sweet. Just makes me feel like, why am I getting a physical exam? But we can see there's some tenderness to palpation. Keep in mind, a lot of these people have that psychosocial somatic type of thing. So you go to touch their stomach and they're gonna like cringe. And every time you palpate it, they're gonna say it hurts. So just be aware, very exaggerated symptoms. But we meet our diagnostic criteria. So at least 1 day per week in the past 3 months. So usually 2 the following. They're going to get relief when they go to the bathroom. So kind of have a change. There's onset associated with change in defecation frequency, whether that's too much or too little. We talked about more than 3 times in 1 day. We talked about less than 3 times in 1 week for your C versus your D. And onset usually change in stool form, which is why we have that awesome Bristol chart. So we can have an idea of that. Because I really don't want somebody bringing in like their phone and be like, well, it looks like this. And like, just point on the chart, okay? Just point on the chart. So, additional supporting criteria right here. So, pain, defecation, we talked about this. Abnormal stool patches. Passage of mucus as well. We want to make sure it's more of a mucus and not more of a fat-containing stool. And then bloating and distension as well. What do we want to make sure that we're not missing other things? We ask those questions, those red flags. But if you want to, we can get some routine screening labs because they're going on long enough. We want to make sure it's not something else. So CBC, CMP, maybe we want to check a UA just to say some people are poor historians, and maybe that abdominal pain is from recurrent UTIs or something different. So we can screen for that celiac disease. I would definitely know what the screening things are. There's certain labs that we order, right? An IgA, and then we go to an IgG, and then what is the confirmatory thing for celiac? Maybe endoscopy and biopsy. Biopsy is the surefire thing. Just be aware of those. Right, but other types of things, plain films for C, screen for celiac, and D because those people have diarrhea. So just gives you an idea. The C, just to confirm, yeah, you are really backed up. You are FOS. Okay, we reassure these people because again, psychosocial aspect. We also want to make sure that we're taking all the organic etiologies. So as an emergency medicine guy, I can tell when somebody comes in and they're already super hypochondriac. They freak out. That's when I have what I call is what is your expectation of this visit today? And you can do that in primary care as well. So what is your expectation? Well, I want to try and take all the bad stuff off the plate. And then so we can at least get it figured out that maybe it's IBS. So again, a lot of anxiety with these people. A lot of anxiety because they have to go to the bathroom all the time, or they lose their bowels, and now they got to change their underwear again for like the third time that day. Anyway, going to the bathroom, not much to worry about. Well, is everybody watching what I'm doing? Does everybody see how much I go to the bathroom or not go to the bathroom? So, encourage these people to have a regular meal pattern. So, not eating less, not eating more, just eating regularly. Smaller meals, preferred smaller meals. And then reduced intake of all these different things. And that gets into what we call the FODMAPs. This is what they want their diet to be. So fermentable monosaccharides and polyols. So this eases those symptoms because these are things that cause more gas production, more problems in their bowel. And unfortunately, things that are good, milk, yogurt, ice cream, you got wheat-based products, breads, beans, lentils, certain vegetables, you look all that stuff up, they can, and you got to stay away from apples, cherries, pears. So that's what that diet is. Other potential things that we can do for them with reassurance is that D, I'm going to make sure that that's not due to lactose, and that's not due to gluten. So with our C, people do not get enough fiber. It's a first world problem. That's why we have so much diverticulitis as well as irritable bowel, specifically type C. So we need to get those people taking more fluids as well as more fiber. A lot of Americans, they'll drink coffee, they'll drink beer, but they don't drink enough water. How do I equate that to people? You should be drinking half your body weight in ounces per day, and that's just sitting inside in the AC. That way they can break it down. Well, should I have 8 glasses or 9 glasses? How big are the glasses? I don't know. That's why I just give it to them in ounces. So, with any of these people, yes, a sedentary lifestyle is not good, so we do tell them to increase their physical activity. And then potential, if we are seeing that there's a lot of anxiety and depression, we can refer that person to a behavioral health counselor or whatever and focus on these cognitive behavioral therapy, maybe hypnotherapy, maybe some relaxation. But as far as that, whatever we reach for, this is your money slide right here. I just told you, like, don't pay attention to the 28 other slides from this particular section. I would pay a lot of attention to this one. Okay, osmotic laxatives is what we try first. Osmotic laxatives is what we try first. And we're going to go on to see where it goes. And then that specific medication that helps out with that. Why does that work? Because it causes everything in the GI tract to actually secrete more fluids, more everything, so these people start getting softer, poop, and go regularly. Much more regular. Because what did I say with these, like, less than 3 times in a week? So, I'm not trying to get into anybody's business, but you should be going more than 3 times a week. And now when we deal with our D, loperamide, that's what we're going to try first. And make sure you read up on exactly how to prescribe that. That's 2 pills after the first loose stool. You can take 2 after each additional stool, no more than 8 in a 24-hour period. And we're going to have them go the other way. And then there's all these other different types of medication, but we're going to try that first. So off-label use is kind of weird, Zofran, but just be aware that you should, when you're reaching for electronics, right down here, that's severe diarrhea. These are people who are probably going 5 to 6 times a day, maybe even more. We're going to reserve that for female patients only. Female patients only. It causes too many other issues, GI issues for gentlemen. So, only. And then potential to progress to antibiotics for people that have significant bloating. Why are they having bloating? Because too many sugars in there. Now it's producing gas, which too much sugar, not a good thing. Too much sugar in stasis, and now we're dealing with infection, gas producing organisms. We can potentially, with significant bloating, get them on these types of medications. Different things that are out there, antispasmodics. I will prescribe these sometimes. These are people that are having significant abdominal pain that deals with peristalsis. We can help them out there. Just be aware if they're taking too much of that for diarrhea types of issues, we can just reverse that back the other way. And then again, your psychotropic medications. I used to be very against any type of psychotropic medication. I always felt it was a crutch when I first started out as a PA. Here's the deal, people don't have time to go see a psychiatrist all the time, don't have time for cognitive behavioral therapy. And if they're a leader in your unit, a squad leader, platoon sergeant, first sergeant, company commander, they don't have time to mess with that. Leaders typically come to see the doctor the least because they are busy taking care of soldiers and airmen and all that fun stuff. So just be aware there's other types of things. I would probably do that in concert with my behavioral health colleagues. So just be aware of psychotropic agents not used for their psychotropic effects. They actually help out with calming the patient down, and they do work on the GI tract as well. So don't try and throw all those in together. But you should be treated separately. That's why I like to send them to see a behavioral health person. All right. Probiotics, no proven clinical value at this point. Now, you might have a different idea of that, or you've read some newer studies, that's fine. But right now, we're seeing that it's placebo, but if you're dealing with somebody that's having anxiety or depression, and they want to try something that's more healthy and natural, sure, give them oral. It's not something you're going to prescribe from the pharmacy, it's something they can go pick up. So, maintaining a good relationship, so being honest with your patients, telling them, hey, here's what you need to do, and then being honest with you, hopefully. So educating them as much as possible. Okay. There are more worthy websites. I'm telling them don't just be Googling everything or WebMD, because people will come in for all types of stuff. But you got a lot of different medications, so let's do trial and error with that and see if we can get things figured out. Again, expectations with that patient. Hey, we're going to take all the bad stuff off the plate. This is going to be a lot of what I need you to do, whether that's fiber, drinking more fluids, not have a sedentary lifestyle, being compliant with the medication we give you. So I put a lot of that stuff back on the patient. So are they going to come in and be honest with you next time? I hope they do. I hope they do. All right, questions on irritable bowel. It's my favorite lecture next. Has anybody other, like biochem, you guys get into vitamins and that stuff? All right. So I'm going to tell you right now, there is a bunch of pathophys in here. I'm not going to get too knee deep in that. I need you to be able to look at what types of vitamins and look at the trends that we're going to see with that. So pretty sweet lecture on hypervitaminosis and hypovitaminosis. There are some stuff out there that you cannot overdose, or they have not documented it yet. But look at all these types of things are important that we look at these, because we want to be able to identify if there's any deficiencies. I'm going to tell you right now that a lot of these are not going to be necessarily first world problems. We do a pretty good job of getting access to that, but people coming from other walks of the world, their country, our third world folks can sometimes deal with some of these things. So I do want you to pay attention to the fact that you have all these different B vitamins, but those B vitamins equate into something. So let me talk about these. So, all needed to sustain health. So extremely diverse in what all of these do. Extremely diverse. Now we get knee deep into that. These are enzymes, and these work with coenzymes. A lot of these vitamins interact with each other. Different hormones in the body, especially certain biochemical substrates. And I think to talk about substrates, that's things that the body needs. What does the brain need? What substrates does the brain need? It needs two things. Glucose and oxygen. Good. Okay, you guys understand that stuff. So, get into this next slide here. So, these function, each micronutrient, if you look at all this stuff, it's going to function a little bit different on everybody, which means we have certain amounts that we want to talk about. We'll get into that your next slide. I just realized how that gets distributed in the body, the older people are, all these types of things can really affect. What other medications do they take? Why, if a patient is on thyroid replacement, that's the first thing they should take in the morning and not mix with anything else. We're talking about micrograms, pretty important, and I think you had thyroid disease talked about today. Okay, so just be aware of that stuff, lifestyle, obviously pregnancy. Now they have this crazy thing called inborn errors of metabolism. So that is something that a person is born with, and any number of things, it's going to affect how much they absorb carbohydrates, sugar, protein, fats. I heard something called Wilson disease. This has to do with celiac as well. How much they absorb. Is it a faster transit through the GI tract? They don't get enough time to absorb the nutrients that they need to. Just be aware of all these different factors. But we have that recommended dietary allowance. This is what the U.S. Institute of Medicine, of National Academy of Food and Nutrition Board, they say, here's what the normal person needs. Now, could you be more, a little bit more? I want to be careful that we're not getting into toxicity, but they want to give you, hey, here's your maximum level. So you got several that are fat soluble, A, D, E, vitamin K. And vitamin K used for?
Bleeding.
Has a lot to do with clotting. What is vitamin K a antidote for? Warfarin, yeah. We don't see a lot of people on warfarin anymore, but just so you know. So I want to make sure they don't have underlying inflammatory bowel disease. Cystic fibrosis is a big one. And then all the others are water soluble. And just so everybody's aware of what the words mean, obviously excess toxicity, we're going over that recommended daily allowance. And if it's below that, maybe we're not going over the recommended daily allowance, but we have some underlying medical problem that's affecting that. Just be aware of deficiencies. Again, deficiencies typically in other parts of the world. Vitamin A, right here. So family of retinoid compounds. What does that mean? That means it plays a big role in the eyes. That's what I want you to pay attention to. So if you have somebody come in with having eye complaints, and I'll show you on the very next one, but it has that component of Versyn and iodopsin. So those all have to do with the cones and the rods in the eye. Okay, so vitamin A, very important that we're having these people take in as much of this as we can. So and that's usually in micrograms, right there. Micrograms 900 for men, 700 for women. I don't remember seeing anything on the test where you have to remember those numbers. And I'm never a big guy on asking numbers anyway with that type of thing. I need you to understand concepts. So, not going to see this a lot in the United States. What does that mean? You need to ask somebody where they're coming from. Maybe the accent doesn't give it away right away, but it doesn't matter. So, a lot of these people, if they are in the U.S., it's because of some fat malabsorption syndrome underlying they have. But again, very common in developing countries. The important thing we see right here. And I love Major Kelly for making me learn new words. It's right there, night blindness, diplopia. So we have some others named pathological dryness of conjunctiva and cornea, xeropenia. So that causes these BITOT spots. And I think I got a picture here where I'll show you that. Corneal degeneration as well as softening. So what are we talking about here? I need to say, oh, if I get asked a question on the test and somebody's coming in there having trouble seeing at night, they're having dryness of their eyes, we need to pick vitamin A, that's their deficiency. So, clinical diagnosis, yes, you can order retinol levels and give you an idea that there's some underlying thing that's not that definitive. We want to start treating them with a pretty healthy dose right at the bat for a week. And if it's advanced, it's going to be at least 5 days, moving that along. And that's in international units. Let's say we give them double that. We're not paying attention. We're giving them double that. Well, here's the things that are going to happen. It does not sound like I want to get vitamin A toxicity. I have a bunch of different symptoms here. A lot of abdominal stuff, and then these people are getting tired, headache, papilledema. What does that mean? Probably they're getting swelling inside of their brain if it's pushing on the back of the eye. Back of the eye. So intracranial hypertension. So this can be like causing, what's that called? There's a couple different names for it. Pseudotumor cerebrae, or the new hotness. Idiopathic intracranial hypertension. I would say it's not that, because it's not idiopathic. We know what's causing it right here. And then skin exfoliation. So why somebody would take this much vitamin A is beyond me, but toxicity symptoms, yeah, they can start getting ataxia when they can't walk, right? Losing hair, cholesterol's going up. It's attacking the liver, and then visual impairments. So it's crazy. Not enough vitamin A, but if you get too much, you still end up with your vision going. And then this weird thing, it made me think of that comedian. Like, that Carrot Top? No, it's not. Right? Carotenemia. So yellowing of the skin that happens too much beta carotene. Provitamin A. Like too much carrots. So we see these in kiddos. Allergy to a lot of vegetables. So it looks like they're jaundiced, but it will not be in their sclera. That's how you're going to differentiate it. It's not in the sclera. This is benign. I always think that maybe, just maybe, our president has this. Just maybe. I don't know. Anyway, moving along. So, again, I'm not going to ask you a bunch of questions on pathophys, because I didn't see anything on there, but we need to differentiate some of these. So, thymine, what do we usually see this? Who are we giving this to? These are going to be your alcoholics that are going to come in, and then we're going to get all this weird Mickey encephalopathy and stuff. But you just realize this is going to, with those coenzymes, and several other metabolic processes that happen. But this thiamine has a lot to do with brain function. It helps convert food into energy vital for proper brain and nerve function. So we're going to see some neurologic types of issues with that. We want to make sure that in women that are pregnant, lactating, we give them a little bit bigger dose than what we would. So do order a lot of pregnancy tests in the emergency department. You should order a lot of pregnancy tests where you are too, because I would hate to have a woman that's pregnant and she's not on vitamin supplementation. Okay? Folic acid, now that kid's neural tube's not going to develop properly. Tell a lot of people in the ED that they're pregnant, and I don't care what they want to do, if they want to keep the pregnancy, but you are going to leave the emergency department with prenatal vitamins. So you do not want to miss those things. So how do these show up? Two different phenotypes. So beriberi, remember B1, beriberi, as well as Wernicke-Korsakoff. So most of these thiamine deficiency due to alcohol abuse. Why does alcohol just depletes the body of thiamine? Just depletes it. So unfortunately, it's very common in the endemic Asian populations because it's strictly on a rice diet, not getting enough thiamine in there. How do these look? Well, we have our dry beriberi, which deals with the nervous system. So peripheral neuropathies, impairments, extremities, limb pain, paresthesias, meaning shooting pains, and now we're dealing with loss of deep tendon reflexes, which is different from wet beriberi, which is more of a cardiovascular thing. We're going to see it strictly acting on the heart, so peripheral vasodilation, which means that's probably going to cause them to be hypotense, but they're tachycardic. You can go to high output heart failure. The heart's getting bigger, but it's just backing up, and we're dealing with pulmonary edema as well as peripheral edema. Looks a lot like CHF. Versus this one, encephalopathy right here, or Wernicke-Korsakoff. Okay? We are going to see some ocular motor dysfunction with this. How is that going to look? Nystagmus. And then ophthalmoplegia, which just means we talked about this before, that's paralysis of the eyes. So that's where we check for extraocular movements. They're not going to be good with these folks. And then can progress to gait ataxia. And then late manifestation of this, Korsakoff syndrome, means it has started out at Wernicke's, progresses to this worse amnesia, impaired learning. Here's a good visual for you folks. A lot of people look pretty congested. That's just because they're not taking any vitamins, probably drinking all day, probably not beer, probably crazy stuff. These are just some slides for you to look through and see these types of things so you can separate them. You get a little bit of a visual if you're a learning type of person on visual stuff. So Wernicke's and encephalopathy versus the Korsakoff right there. Either way, with Wernicke's, it's going to progress untreated to coma and death. Can you take too much B1? Slide says no, you can't. Why? It's the body excretes it. The body excretes it through the urine. The body excretes it through the urine. Let's get into this. So riboflavin. So bunch of different actions on this. So if these two major coenzymes, flavin, mononucleotide, and flavin, adenine dinucleotide. So these are involved in energy metabolism, also play a role in cellular restoration and antibody production. Like I said, nothing on the test like that, unless you just want to show off people how smart you are. Talk about all the pathophys. I think everybody dumped most of that from the first 2 semesters here. Like, I gotta fit more stuff in. And every time I put something in, something falls out, so let the pathophys go. Let's look at this right here. Conjunction with other deficiencies, so if you're thinking B2, riboflavin, and you think it's running with some other things, causes malabsorption, anorexia, other things. Yes, this is everything that's happening right around the mouth. So cheilitis, that's usually It can be all over the lips, but usually in the angle, which is why they cause that angular stomatitis. Atrophic glossitis, so we're going to get this smooth tongue now. It's going to lose all the ridges on the little villi. So, and then seborrheic dermatitis. What is that? What is seborrheic dermatitis? I know you guys get derm next semester. But what's the layman's term? So I'm not going to ask my kid to go seborrheic dermatitis, and I'm going to say, hey, dude, you got dandruff. It's usually what it starts at. Overproliferation of yeast. And sometimes, if you're northern European descent, it'll come down in the face too, getting eyebrows, nasolabial folds. Anyway, I'm going to test you on that. I digress. You can't overdose on this either. Okay, no toxicity from these two. So let's get into niacin. So this is central to energy metabolism. So specifically cellular respiration. So this is working down at like microscopic levels. Just be aware of that. It's going to help out with fatty acid breakdown. Anybody ever hear of tryptophan? Where can you get that from? Turkey. It's like the ultimate date rape drug. I go sleep every amazing. I'm using Turkey right now. Okay. Niacin. Here's what I need you to know. Here's your money slide. Here is your money slide. So, pellagra is what we're going to see. That's just a generalized term. So, cause from deficiency of B3, but also can be from tryptophan, so ear turkey. Dermatitis. Make sure you have somebody comes in, has dermatitis, diarrhea, dementia, death. Potentially, now they shouldn't be coming in unless CPR is in progress. They can just go to that for a good visual right here. You don't want to look like this gentleman. You don't want to look like this gentleman. So that's from not getting enough. Now, if we take too much, and by the way, some people do take niacin, but don't ever take too much unless you want to feel this, and it's not feel good. I don't know why I did it, but I did it once. I felt like I was like wanted to burn out of my skin, continually flushing, nausea, vomiting, messes with the other T's. So at least we got an antidote for it. And an antidote for it can be controlled with aspirin. Again, I don't recommend doing that, but just it's out there. All right, let's get into vitamin B6 and finish up here. Get you guys moving. So I want you to pay attention to this B6. These are all derivatives, pyridine. So this has to do with glucogenesis. So it's going to interact with a lot of these other types of things. So anybody aware of what this is an antidote for? B6. It's right there, isoniazid, which is what we treat TB with. So a lot of people are on this, which means I worry about it because somebody gets treated for TB for a very long time, and they have the bottle at home, and little kiddos, up until they're a certain age, they like to taste test everything. So unfortunately, this does happen as far as overdoses. If you want to look up some cool stuff, just look up what pill can kill, and it's all these things we need to be careful with little kids, especially when they go visit grandma and grandpa. Beta blockers, bad. Again, it's going to have a lot of these mouth types of issues, B6. As far as tongue, again, but we also deal with some neuropathy types of things. If we were to get a CBC on that, we would see a microcytic anemia. Was that an MCD below 80 typically? All right. Maybe it was some iron deficiency as well. So we don't usually see a lot of toxicity with that, but we're taking a ridiculous amount. So most people don't go and be like, I'm going to take more than the recommended dose. But I'll tell you, a lot of older folks, and they start getting dementia, Alzheimer's, that type of thing, they will unfortunately sometimes take their medication too many times. Well, the gentleman in the emergency department last year, they decided to take his long-acting morning insulin at night. Luckily, his wife realized it and brought him. So 6 amps of D50 just to keep him going. That dude had to go on to sleep And then game over. Game over. All right, digress. Let's get into vitamin C. All right. All these different things that it's going to react on vitamin C is very important for the body. Make sure you're getting plenty of vitamin C. There's a lot of theories out there that people take high dose vitamin C, they start getting sick. That's a thing. It is probably one of the best tasting vitamins, I will say. But what do we worry about today, right here? Now, I don't see this a lot anymore, but what did they take on ships? Specifically the British. Limes. Hence the term liming. That's how they got that. So that was to prevent scurvy. So American sailors started calling them limeys because of all that stuff. So don't see this a lot, but yeah, potentially somebody in a poor little deserted island doesn't have any limes, coconuts, whatever. Should have got shipwrecked on a better island, whatever. And this is how that shows up. I got a slide for you here, but we're going to look in their mouth, okay? And look at their skin. Arthralgias. What's a hemarthrosis? That's a fusion on a joint, but that's usually from blood, that's from bleeding. And all these things that vitamin C, anorexia, and potentially can have sores, anemia. There's a good picture. Pretty significant gingival bleeding right there. And some very interesting type of cutaneous examples that happen with skin things that show up. So, too much vitamin C? Yes, that can happen. It can happen. You can have a positive, false negative guaiac. I think that's very interesting. But probably the biggest thing to worry about is a person has an underlying stone former. Underlying stone former. We need to be very careful with these folks. If we're giving them too much vitamin C, it can propagate worsening kidney stones. And if you know about kidney stones, calcium oxalate is going to be your most common kidney stone. It's common also, whatever. It starts with calcium. And just be aware we don't want to do this to them. What I want you to take from this slide, what does vitamin D help out with? Okay, so the body absorbs calcium. What else does vitamin D play in? I'll tell you, if any of you go to phase 2 out at Madigan, Pacific Northwest, it's great for 2 months out of the summer. And the rest of the time it's raining. Once you get there, they're going to check your vitamin D, and they're probably going to start you on a supplement. Very easy to fix that stuff. But we want to make sure that's helping you out. You can get depression with this, and you can have some pretty significant bone loss. It's not taken care of. So when kiddos have that, what do they end up with? Something called rickets. They can also have difficulty with their fontanelle and their head closing. I think this is a really weird thing. I've never seen it. Parietal and frontal bossing. Feeling the front of their head grows out. It's very, very weird. If you want to go total Cro-Magnon, I mean, do that. Okay, absolutely. So thickening the joints, but then kind of the pathognomonic for this stuff is going to be the Genu-Varum as a kiddos with rickets. You don't see this a lot in the United States. I've seen it several times in Afghanistan. I think, but that's just a sign of vitamin D deficiency. There you go, right there. Worry about adults because they can get osteomalacia. Usually starts out asymptomatic, but we want to see it starts affecting their spine, pelvis, lower extremities. Yep, muscle weakness as well. Gait difficulty, and we worry about something called a pathologic fracture. Pathologic fracture that's not usually from some amazing force, a car accident. Austin Powers judo chop. No, probably not. So there's just right there, just walking around and break a few. We have not established what the upper limit of this is, but if they get that, it causes hypercalcemia, which can lead to all these different symptoms right there, confusion. We have some urinary symptoms, that's peeing all the time, drinking all the time. People look like they have DKA. All right. We'll save the rest of this for tomorrow. Are we good with that?
Yes.
We'll finish out the last two lectures in the morning, and then I'm just gonna rip it right down that test and tell you, for you, things that I would focus on. Since we did this whole midstream